Hello, everyone.
Hi.
Good to see you, Dr. Ejam.
Thank you. Thank you.
Hi, Elmo.
Hello, Professor.
Long
Professor
time no
Kim, you're
see.
driving. You're
Yes, I'm
driving.
now driving.
Okay, safe driving.
Okay.
Start now. Yeah. Shall we start now? Right now, I'm not sharing anything. When I, so that's long. That's tomorrow. Isn't today. Okay, dear friends, we are barely 30 seconds away from the start of our World Congress. We have started live streaming on Facebook. We have started live streaming on YouTube channels simultaneously, and I think I will now officially start with the welcome address. We're just waiting for the clock to be at sharp 11. We are going to try and stick to our time schedules so that we can help each other as colleagues, as friends, and we can spread our love for endoscopy, each one of us, worldwide. So I take this opportunity to officially announce this Congress is open. On behalf of the chairman of this Congress, Dr. Sameh Al-Morsi Hassan, I welcome all of you. I, Dr. Malcolm Pestinji, on behalf of Endoscopic Spine Foundation India, and my dear friend, Dr. Anand Kavi, who is the co-chairman of this, co-organizing secretary of this Congress, and who is also now the chairman of the Endoscopic Spine Foundation, who has taken charge in this month itself. He's planning our future. So I welcome all of you. I welcome all of you panelists today morning. Good morning to all of you. The world of endoscopic spine is today covering the entire spectrum of degenerative spine diseases. We are working with various streams of spine endoscopy, principally unilateral biportal, monoportal, interlaminar, transforaminal, epiduroscopy, sacral epiduroscopy, Dastandu. All these streams of spine endoscopy are today growing and flourishing because they're truly minimally invasive, very little muscle damage, and patients are fit and fine and on their way on the very second or third day. Endoscopic Spine Foundation India, along with Dr. Kavi and Dr. Bhupesh, was our brainchild. We are India's foremost, what we call ourselves as endoscopy school, because we teach endoscopy. And today we encompass the main three streams, that is transforaminal, UV, PSLD, and interlaminar. Each form of endoscopy that I have been practicing and seeing and merging today has some advantage and some shortcomings somewhere. Merging the streams of endoscopy has been of great help to me, and I see the near future of a global endoscopy, a 360-degree endoscopy developing with mastery over all forms of endoscopy. The basic core is to give better patient care and to be better result oriented. We are streaming live on Facebook. We are streaming live on Endospine Golden Park Hospital channel and on EWNC Academy YouTube channels. So I now once again take the opportunity to hand over the talk to Dr. Sameh, who is our chairman and the chief brain behind this Congress. So Dr. Marcy, please take over. We'd like to hear you for a few minutes.
Thank you, dear friend Malcolm. It's a great honor to me to start this Congress, which will be a bright star in endoscopic spine surgery in all over the world. Dear friends, professors, and colleagues, great honor for me to be here today with all of us to follow endoscopic spine surgery all over the world and its updates. Thank you, dear Malcolm. It was a great effort for last 6 months to bring this Congress up. Thank you all for joining us, and I hope you will enjoy all sessions and lectures. Now we start our Congress by first speaker. Please, Dr. Malcolm, introduce him. Thank you all. Thank you.
Thank you for your kind words, Dr. Marcy. You do me a great honor by appreciating this effort. And believe me, this effort is to bring and give platform to all the eminent speakers in the world of endoscopy. We are trying to grow every year compared to our last year and previous year. Before that, today we are having more than 54 speakers from the worldwide and encompassing 27 countries worldwide. Hopefully we'll see a bigger Congress, maybe not virtual, but an actual Congress coming in very shortly. We just hope the travel restrictions and the post-COVID world opens up and we can all meet dear friends and colleagues. I will now request Dr. Xavier to start with his lecture so that we can proceed with the Congress and save up on some time. So Dr. Xavier, the stage is open to you. Please start your first address. Welcome, sir.
Thank you very much. And let me share my presentation. Can you see my screen?
Yes, we are able to see you loud and clear, sir.
Perfect. Okie dokie. Okay, thank you very much for inviting me to this great meeting. It's a pleasure always share my thoughts with friends, with professors, with all the people that I know that they are so amazing doctors and spinal surgeons. So I'm Dr. Javier Quillo from Mexico, and today I will share with you my talk about unilateral biportal endoscopy for cervical degenerative disease. This is an overview of the technique. So let's go to start. I have some specific learning objectives, for example, basic principles of this technique, the rationale, UV approaches to the cervical spine, case examples, and conclusions. So this technique was reported in 1996 by Dr. D'Antoni in Argentina, but at that time, the indications were very, very specific. Only lumbar epidural pathology related with the soft intervertebral disc. So soft discernations were also the only indication, but with the time, especially in South Korea, by masters of spinal surgery, they expanded the indication, especially for degenerative spinal diseases. So we have right now a lot of approaches and a lot of options to treat spinal degenerative disease through this biportal endoscopic technique. So we can systematize the technique in 2 steps. For each learning, so the first step is to know how can I do a correct triangulation of the ports? How can I collocate the surgical instruments with the endoscope? And how can I confirm a proper inflow and outflow system of saline? Then I can observe and recognize the bone landmarks. All of these ideas means that we need to know how to perform a unilateral biportal approach to any region of the spine. Then when I can perform fluid these systematic steps, I can reach my biportal endoscopic technique specifically addressed to any pathology of the spine. So I can complete the procedure previously planned. So another basic principle is the anatomy of the posterior cervical region. For example, the surgeon needs to know the deepest cervical muscles. In these approaches in the cervical region, we have to know the transversus spinalis group, that is the multifidus group. So they are stabilizers to prevent forward head position. We have to preserve as maximum of possible this group. In this picture, we can recognize the multifidus muscles, and the surgeon works below the muscle in a epiperiostal space. So this is a space that virtually is filled with connective loose tissue, fat, and we can enlarge this space with the hydrostatic pressure with our system of inflow and outflow of saline. The second thing is we need to know the bony elements. Here we know the B point, but the B point is not only the idea of point specifically confluent of the superior articular process and the inferior articular process. We need to have special consideration. Professor Harrison Kim and colleagues, they published recently journal, in a journal of neurospine, an article that they describe how in young people the B point is far from the thecal sac, and in elderly people the B point is nearest to this thecal sac. Here in this intraoperative image, we can observe by unilateral biportal endoscopy the B point. It's a very nice image, intraoperative image with the endoscope, but this B point has three-dimensional areas and surfaces. So the B point in the surface of the bone is only a point, but when the surgeon drill the B point, you can reach more bone landmarks. Here, for example, we can observe the edge of the thecal sac. Here, the descendant process of the superior articular process, and here the ascendant part of the SIP. Another important landmark is the ligamentum flavum. The ligamentum flavum, it's very important because we need to reach the attachment, the cranial and inferior attachments, and after that we can detach completely or in piece by piece. But we have to take care the ligamentum flavum because below the ligamentum flavum are different structures. For example, the peridural membrane and some meningovertebral ligaments. So they are very important because if we destroy or damage without any caution, we can occur a dural tear, and this is very, very serious in the cervical spine. Also, we can retract the thecal sac by detaching the ligamentum flavum with any cautious. Another thing is the position, the prone position, and then you can drape the patient. We use for these techniques as familiar surgical tools, as we know. The hydrostatic pressure is another basic principle. The recommended hydrostatic pressure for this technique is between 4.41 centimeters of water to 31 centimeters of water. So the rationale of this technique is minimize the collateral damage to the paraspinal tissues. Obviously, we can obtain maximum visualization, magnification, and illumination during the procedure to offer safer surgery and also to get short-term outcome. Why? Because we know that stronger predictors for a good short-term outcome is the efficacy of nerve decompression plus decrease the extension of iatrogenic collateral damage to the spinal tissues or paraspinal tissues. And finally, not everyone can uniportal endoscopy, but all surgeons are able to open procedures of the spine. That means that biportal endoscopy is very familiar for any spine surgeon, orthopedics or neurosurgeons. So we have two main approaches to the cervical spine. First one is direct paraspinal approach, and the second one is posterior inclinatory approach. These approaches were reported by masters of the spine, especially in Korea. There are not too many publications about that. The direct parasagittal or paramedian posterior approach to the cervical spine is very highly effective in decompressing unilateral or bilateral the dural sac and reaching the proximal portion of the exciting nerve. We can perform ULBDs, foraminotomies through this approach. We can get access to the axillary space. And however, since the approach is perpendicular to the facet joint, the surgeon could need more facet joint removal in some cases to decompress completely the exciting nerve. The other technique is the posterior cervical inclinatory approach. It's highly effective to decompress longer extensions of the trajectory of the exciting nerve by undercutting only the facet joint. So we can make a tunnel through this exciting nerve, around the exciting nerve, and the possibilities to use other instruments to bone remove are feasible. For example, kissels, you can remove the tip of the SIP. However, its precise nature makes it impossible to address the approach to another pathology target because the approach is oblique. So medial to lateral approach is the nature of this technique. Here you can observe also the other approach that is feasible in the posterior biportal endoscopy. Is called ULBD, bilateral aminotomy for unilateral aminotomy for bilateral decompression. The steps are similar to the lumbar spine. However, we need to be more cautious in the cervical spine. First, you need to recognize the B point. Then you can decompress the bone elements starting for the superior or cranial lamina, and then inferior or caudal lamina, and finally bilaterally to decompress the thecal sac. These are case examples. This is a 61-year-old male with C5, C6, and C6, C7 right foraminal stenosis and clinical radiculopathy, plus severe axial pain. We treat this patient by a UBE, posterior inclinatory cervical foraminotomy in the right C5, C6 space and C6, C7, plus an ACDF C6, C7 to treat the mechanical pain in the neck. So you can see how the high disc space is collapsed in preoperative and postoperative is restored with good lordosis, but we perform the foraminotomies through the inclinatory technique by UBE to decompress the exiting nerves. This is an example of the video, intraoperative video of C5, C6 decompression through an inclinatory cervical approach to the UBE. Here is the preoperative TAC CT scan where the foraminal stenosis can be observed, and here the decompression is reached. This is another case example of a 83-year-old female with cervical spondylotic myeloradiculopathy and cervical spinal stenosis in C4, C5, and C5, C6 with a modified Japanese Orthopedic Association score of 12 in the preoperative and right C5, C6 foraminal stenosis. We treat this patient by a UBE, ULBD, C4, C5, and C5, C6, plus UBE ipsilateral foraminotomy in the right side. This is an intraoperative video after decompression of C5, C6 level. And you can observe in the comparative radiological outcomes in the MRI, here in C5, C6, the trajectory of the foraminotomy and the postoperative decompression of the thecal sac. We can obtain very good radiological results and very good clinical results if the process of the surgery is fluid with any issue during the surgery. As a conclusion, biportal endoscopy for cervical degenerative pathology covers a broad spectrum of diseases, such as foraminal stenosis, discernation, and cervical spondylotic myelopathy. The short-term outcome reported in a few studies is acceptable. However, the technique requires training and a stable learning curve and gut judgment for deciding and electing the proper patient. So more evidence is necessary to demonstrate the procedure-related advantages. Thank you very much for your kind attention.
Xavier, that was a wonderful and a very crisp presentation and perfectly concluded on time. I now request our next speaker, Dr. Alfonso Garcia, to please start his mic, camera, and start his screen share. Dr.
Thank you. Thank you, Doc. Yes, I'm here. Can you hear me well? Thank you.
Please start your screen share.
Thank you. So I'm going to share my screen. So please let me know if sharing of the screen is okay.
It's perfect. Please go ahead, sir.
Thank you. So thank you very much, Dr. Pestonji, for having me here, for the invitation. Dr. Baru, I'm very honored to participate for the second time in this important meeting. I'm also very delighted to see familiar faces again. I have to apologize because I had to make minor adjustments to the title of my today's talk. So transforaminal endoscopic foraminotomy and other complex decompression cases. This is my disclosure. And just to very briefly explain to the audience where I'm located, I am in the city of Tijuana, Mexico, which is the most northwestern part of the country. And Tijuana is very well known nationwide for its museums, art, music, obviously scenic roads, and definitely food and wine. But also it's now becoming the #1 choice for health and wellness tourism. Since 2020, more than $800 million have been made in investments. So now is the fastest growing health and wellness tourism destination in Mexico. It borders with the state of California in USA, and it's very well known for dental, weight loss, plastic surgery, cancer, alternative medicine, and lastly, orthopedics. So spine surgery is not there yet in our most thoughtful programs in healthcare. So endoscopic foraminotomy, according to this historic line, it's actually not that old. So it started in the early 2000s. And now also according to history and what is happening, what has happened since 1994, we are now approaching the golden age for foraminotomy. So what types of foraminotomy do we know? Well, we have two basic types, which are percutaneous, or the one that is taken through a direct visualization with the use of endoscope, and a combined one. So for percutaneous and endoscopic, for percutaneous foraminotomy, we have different tools and different drill bits, ones that are more aggressive than the others, ones that are more safer than the others, but it all comes down to what the surgeon prefers and what he feels more comfortable with. And now for direct visualization, we have evolved to many different kind of drill bits and high RPM bone drills. So we have now reflective bone drills that angulate and actually facilitate the work for decompressing the foramen. For the combined technique, we now have some trefines that actually fit through the cannula, and you can see while looking through the scope the direct foraminoplasty done with the trefine. We also have very up-to-date information on how we can better target and identify our safe zones in the foramen. And this have not changed. So now we know that there are various sites from the SAP down to the pedicle and down to the base of the pedicle that we can target. And these bony land points actually are the safest zones to target once we identify the foramen. So we have developed this green zone, which is the safest zone, and the red zone, which is occupied mainly by the exiting nerve root. And we have to remember to keep off this red zone as we enter the foramen. But once we can see the DRG or the exiting nerve root, depending on the level we are accessing, it is perfectly safe to access slowly this red zone. So first, what I've done is develop a safe technique, because once you enter the foramen, we all know that what you see immediately is a blood clot. So I like to palpate these bony landmarks that is identified by the SAP and an arch formed by the SAP and the pedicle. So I like to palpate that with my RF probe. And secondly, I will identify my disc space, and now I can make my way very safely to the lateral recess area. So I always try to keep this image in mind. So what was the strategy I developed through the years right after my fellowship training? I learned from my patients. So I went from very basic approaches to more and more advanced as the patients got more complex. So I went from transforaminal decompressor, simple and single level, to more complex 2-level and a combination. So then I moved on to biportal, which I started with lumbar, then cervical. And then I moved on to interlaminar decompressor from lumbar, ipsilateral, contralateral, and a combination of approaches. And from there on, my new path was to develop a new training plan to approach the cervical area, which for me was the most difficult area to approach. And I went from anterior to posterior. And on the posterior, I did firstly foraminotomy and then bilateral decompression. So what we all know about endoscopic spine surgery, we now know that it has broad indications through very small incisions. We have an improved surgical view and the navigation aid. It is a muscle preserving procedure with less bone cut, as Dr. Quillo mentioned, the sublaminoplasty or the inclinatory laminotomy. It is definitely associated with less blood loss, less post-op pain, reduced infection risk, and fast recovery. It has also been confirmed that it can be used in different settings, such as degenerative spinal stenosis, spondylolisthesis, scoliosis, previous fusion, tumor, and infections. So what is the benefit of full endoscopic surgery? Well, there's a very nice paper written by Dr. Hofstetter and other colleagues of him. In that paper, they mentioned the perceived invasiveness and complexity. And as procedures are perceived as more invasive and more complex, the endoscopic benefit zone actually grows. So this is the area that I'm going to share some cases. I have 3 cases for me to share that fall into this selected benefit zone. So case number 1 is a lumbar foraminal stenosis. It's a revision surgery, 70-year-old male with a previous history of pacemaker, lumbar disc replacement, L4-5, 5S1, which didn't result in a satisfactory surgery for the patient. Then he underwent fusion from L4 to S1 and still was unsuccessful. So he came into my office referred by another neurosurgeon with chief complaint of right buttock and leg pain following the L4-5 dermatomes, numbness, and gait disturbance. On physical exam, I identified dysesthesia, no muscle weakness, and a positive right SLR test. On day 1, I did a right L4 transforaminal diagnostic block he experienced pain relief for 8 to 12 hours. And on day 2, I did L5 transforaminal diagnostic block and no significant changes. So my strategy was to access the right side L4-5 foraminal stenosis. These are the only images I could perform because of the pacemaker was not an MRI safe pacemaker. So my surgical plan was to do a right L4 transforaminal endoscopic lumbar foraminotomy. And you see all the hardware he has because of the prior surgeries. And that actually didn't help a lot during the approach. But still, I was able to place the cannula. And this is the first image I saw. So if you remember from the previous slides, we have to identify that inferior border of the SAP. So usually what we see is anything but that bony wall on the bottom of video view. So that is the pedicle, the SAP. And I had the foramen fully covered with bone. So my first move was to try and drill through it, which I couldn't. So then I tried to move upward to where the exiting nerve root is and try to find the interface between the L4 and the L4 exiting nerve root and build some space from there, and that worked. So I used the ball probe, as you can see me dissecting there, and you can barely see the L4 nerve root. So once I developed a nice working space, which was also very tight, I could manage to put the kerosene rongeurs through that hole and at least take a first bite. So after the first bite was taken, it was downhill from there, and it was very easy for me because I was protecting the traversing nerve root while still keeping a safe distance from the exiting nerve root. So I just followed the decompression all the way down to the wall of the pedicle. And as you can see me taking more and more bone out, I could even preserve some of the venous plexus, the epidural space. And now you can see the traversing nerve root that is starting to decompress at the bottom of the screen. So I continue the decompression all the way down to the pedicle. And you will see the last documentation, video shots and pictures. There's a fully decompressed foramen, a pulsating traversing nerve root. And that was the last picture for that case. Satisfied and happy patient, no pain, walking on the same day with no aid, and left on the next day. So case number 2 is a cervical stenosis with an OPLL, 63-year-old male, past history of dyslipidemia, progressive loss of upper extremity and dexterity, gait unsteadiness during the last 8 to 9 months, at present unable to feed himself or unable to walk, with a Japanese Orthopedic Association scale of 9, pre-op CT and MRI up for discussion. The 2-level compression. So the surgical plan was to do a left single incision with a cervical endoscopic unilateral laminotomy for bilateral decompression at 2 levels, C3-4 and C4-5. So this is a target CT that's from the pre-op planning. I'm sorry, start the case again. So first step is to make an incision centered at C4 and then move a little bit up until I identify the C3, C4 interlaminar space. That's the V point. So in this case, I was able to dissect prior to doing some bony decompression. So that's the midline. over there. That's the midline from the yellow ligament. So I started drilling on the lower edge of the upper lamina. And then I made my way medial, starting at the lower edge of the upper lamina and then the upper edge of the inferior lamina. So I left the yellow ligament intact. It serves as a very protective shield, and actually it makes the bony decompression a little bit faster and safer. So now I'm able to put in the Kerrison rongeurs. And as you can see, the yellow ligament actually starts to detach on its own. I try and keep it as much as possible in place. And now it is very easy to detach in block. So in this first level, I was able to remove in one single step almost 90% of the yellow ligament and this very small remnant. At last, I like to use this angle, up angle rongeurs for removing the rest of the flavum. So that's fully decompressed on one level, both sides. So I now slide. I do the sliding technique. You don't have to do another incision nor access from another point from the same skin incision. You can actually just slide to the inferior level and do exactly the same steps. First, dissect, identify the V point, start to drill, leave as much as of the yellow ligament intact, and then remove it. In this level, it was a little bit more difficult for me to remove the yellow ligament in one piece, but I was still able to fully decompress past the midline to the contralateral side. I'm on the contralateral side right there. And it's fully decompressed on both sides. C3-4. C4-5, C4 lamina, and C3-4 up. That is the size of the incision. It's also called a Band-Aid surgery. So patient is still doing well, and he was able now to feed himself. The last case is a right C6-7 herniated disc. I perform a C6, C7 right side decompression through a full endoscopic laminoforaminotomy. This was one of my first cases, so I did use a stabilizer for the cervical cannula, which made it a little bit more easier to keep my cannula in place. As my first cases, I felt a little bit uneasy, and it is a very unstable approach. So you have to be very careful while holding the cannula in place. So this is a right side approach, decompressing on the lower part of C6 lamina. Also trying to keep as much as possible intact flavum, so it can protect you while you do the bony decompression. Now we can see some of the C7 lamina exposed, the upper portion. Now I'm removing C7. And I leave some of the anterior cortical of the lamina intact, so I can remove with the Kerrison rongeur. And as you can see now, some of the flavum is already detaching on its own. So I detached the ligamentum flavum, and I was able to remove the disc. You can see part of the pedicle there, and some of the exiting nerve root already pulsating. You don't even have to retract the exiting nerve root, which I like. because the less you manipulate on the cervical area, it's the better for the patient. It's a faster recovery. That's the pedicle. And it's a fully decompressed exiting nerve root, fully decompressed foramen. So take home message, learn from every case, grow with your practice. Sometimes we expect this on our first take, but the reality is not. Instrument handling is key, very important. Build academic relationships, network, build teamwork, teach others, share your knowledge, and enjoy the reward of your work. Thank you very much.
Thank you, Dr. Alfonso. That was a wonderful talk, and I really will take that message from you to the world. Learn from every case. Yes, we all keep learning. We all are evolving, and we are all changing the spectrum of endoscopic spine surgery the world over. So that was a very, very crisp and a wonderful talk. Thank you. Thank you, all my colleagues from Mexico. And now I invite Dr. Elmer Jose Alvaro Maceda, also known as EJAM, from the Philippines to start his talk. Welcome, Dr. Elmer. Good morning to you. Please start your screen share. You are on mute, Dr. Elmer. Please unmute yourself.
Thank you very much. Good day, honored mentors, colleagues, and friends. If you can hear me well, please let me know. Is okay?
Hear you loud and clear.
Very good. Thank you very much. I'd like to thank the organizers of this convention, the Egyptian and World Neurosurgeons Community Academy and Endoscopic Spine Foundation India. Specifically, my friend Dr. Anand Kavi and Professor Malcolm Pestonji for the invitation and for eagerly pushing through with this conference despite the pandemic. I'm in the Philippines right now, and we are still on lockdown. Recently, I'm under quarantine. Recently, my resident, who's undergoing training, became positive with COVID-19, and I was exposed to her last Friday. So I have on voluntary quarantine. I'm going to turn off my video to maximize my, speed, internet speed, if that's okay. I will be giving an experiential presentation about the philosophy of learning that I used in cervical endoscopy and how I developed a new technique or a new approach to solve high cervical C2-3 disc herniation causing spinal cord compression in my patient. I have no disclosures and nothing that will affect my presentation. Percutaneous endoscopic cervical decompression covers both anterior and posterior approaches. I will introduce a new approach which hopefully some of you will consider if you are faced with the same case or cases that I will present. First, to discuss how I learned this technique and how I incorporated it in my practice, I will use the Fitz and Posner model of motor learning. 60 years ago, Fitz and Posner proposed a model of motor learning and skills acquisition that centered on 3 stages. In the now classic theory, performance was characterized by 3 sequential stages: the cognitive stage, associative stage, and the autonomous stage. The cognitive stage marks the period in which the goals are established and used to determine the appropriate sequencing of actions to achieve the desired goal. Learning at this stage generally involves the use of explicit knowledge. Movements are slow, inconsistent, and inefficient. A good example that comes to mind is when we learn how to swim. We look and observe at someone swimming, how they're enjoying it, and we decide that we want to learn how to swim. And we will probably do dry swimming and first do this dry swimming and reenact the movements and rationalize the need for each movement to complete a set of strokes, taking into account the breathing, arm and feet strokes, and body turns. On the action sequence, once the action sequence has been determined, the learner enters the associative stage in which attention may be focused on the specific details of the sequence. Determining the appropriate subparts and transitions, the movement is now executed in a smooth and coordinated manner. Movements are more fluid, more reliable and efficient, less cognitive activity is required. This is where the learner understands how each movement is linked with its other movements to create a whole. While at this stage of learning, I divide the procedure into the approach stage, which is understanding relevant radiologic and endoscopic anatomy of the approach. The endoscopic decompression stage, understanding endoscopic view of the pathoanatomy and related structures. And endpoint, knowing that the compression is enough and making a clockwise evaluation of the operative field before ending the procedure. Autonomous stage is wherein the execution of movement or techniques requires less attention and cognitive demand. This happens when the sequences of basic movements become more automatic and the surgeons can free his mind and are able to anticipate surgical events and dangers and recognize impending disasters, thus able to prevent and adjust focus on demand. Even at this day, in this day and age where we have explosion of knowledge and the formation, a lot of information exchange, the old saying that experience is the best teacher still holds true. We learn from the experiences of our own pioneers and mentors. We how we understood, we also learn from our own experiences, how we understood the basic steps of our procedure. And slowly, we try to do training and research to understand some more. That the transition of associative stage to autonomous stage is a continuous back and forth process. Your sense experiences becomes knowledge, and a specific visual spatial motor cerebral pathway is formed that makes the learned or acquired skill automatic and is used in practice. To illustrate this process of learning, I will use a case of a 48-year-old female teacher who complained 4 months non-remitting right shoulder and arm and hand pain with a pain score of 8 to 9. It's slightly relieved by elevating the arm above the head. Pain somewhat decreased in intensity in the 3rd month prior to admission. However, she developed progressive numbness and weakness on the right arm and hand. 1 month prior to admission, the pain recurred. The dosage of medications were increased and rehab physical therapy was initiated with minimal relief. The neuro exam and the EMG NCV showed right radiculopathy at the C7 distribution with weakness of the grip, but with no Hoffman's. Her MRI is consistent with C6-7 right foraminal stenosis, and she was scheduled for a PECD, C6 to C7 on the right side. And here's my OR setup. If you can remember the associative stage, until now, I still continue to divide the procedure in 2 stages or steps that will guide me and the operating room staff in the conduct of the surgery. For this procedure, the approach stage includes localization of the C6-7 V point using C-arm and docking the cannula and endoscopically visualizing the V point by removing a thin layer of the muscles. So you can see very well the V point. Endoscopic. The endoscopic part of the approach is the unroofing of the foramen by doing laminotomy and medial facetectomy. This is accomplished by using endoscopic Kerrison and endoscopic drill. And we can see here the Kerrison removing the ligamentum flavum and exposing the endpoint for this approach stage, the exiting root and the thecal side. Once the bone work is carried out, the lateral ligamentum flavum is removed. Once the dural anatomy has been clarified and the location of the herniated disc is confirmed, endoscopic decompression commences. So here we can easily remove the disc and it's very important to go and above and below the lesion to make sure that the disc is totally removed. So here we can see some more views. We do exploration and then endpoint after exploration. Now, going back to the Fitz and Posner model, I would like to propose an addition to the continuum of the stages of skills acquisition. This is the stage of advancement or formation of new knowledge and expansion of indications and application of new techniques. And this I will illustrate using another case. In the last quarter of last year, 2020, the Philippines was visited by 4 typhoons that brought plenty of devastation in my province, and the one hardest hit was my province in the Bicol region. Our 49-year-old social worker was then very active in relief operations. She complained of sudden dizziness and tingling numbness of the neck down to the feet upon lifting packs of relief goods. She claimed that before sleeping that night, she already noted some unusual tingling sensation of the right shoulder and arm and hand. The numbness progressed to weakness and inability to walk, and she developed electric shock-like sensation from the neck down associated with head movements. Peculiar in this case is that the patient already had a right-sided upper extremity and left-sided lower extremity paresis from a childhood poliomyelitis. However, she's a fully functional person. Also, it's very important to note that in the history, she had a history of thyroid surgery with modified radical neck dissection 5 years prior for thyroid cancer surgery. The neurostatus preoperative is this one, and the patient is really bedridden. The MRI showed a spinal cord compression with edema from a C2-3 disc herniation, and the disc height, though, is not compromised. How do I help my patient? So I had to do my research. The case is not common. The overall incidence of C2-3 disc herniation is 0.2 or less than 1%. Approaches had been elucidated in cadaveric studies. Submandibular approaches were described, as well as transoral approaches. Surgical approaches to the upper disc level have been performed for inflammatory, neoplastic, traumatic, and infectious process. So these approaches are familiar. Here is the illustration of the open submandibular approach. A detailed anatomic study of the open submandibular approach by Russo in 2009 published in the journal Neurosurgery Spine showed the intricate anatomy that the surgeon need to master to ensure a safe approach. And this was discussed with the patients and the relatives, and they were not amenable to have this procedure done. There is also a transoral transmandibular approach for maximal exposure, And literature describes that the transoral approach, which can maximize the exposure with additional mandibulotomy and glossotomy, but these approaches were maximally invasive and as well used cannot not advisable to be used for a small lesion like in our case. And this shows the coverage of the transoral approach. Now I have a dilemma. I asked for help for a discussion with the online discussion with my mentors in Korea, and they advised an anterior C3 transcorporeal approach. And however, the patient has a previous modified radical neck dissection, so I said this is a contraindication. Now my options will be transoral approach or endoscopic approach, and I tried to look for a publication about C2 transcorporeal approach, and I cannot see one in the literature in the internet. So there have been published articles in anterior and transcorporeal approaches, and this was 2009 and 2016. I'm going to show you the serial photos of the planning stage, this for the discussion with the relatives. And this is the positioning that I've done with my patient. The patient is on head holder, Mayfield, with two nasogastric tubes, one for the suctioning and one for going to the stomach. And you can see here the gag, mouth gag to open the oral cavity. And this is my docking of the approach after cutting the a small 1.5 centimeter incision in the mucosa. And first I did a reamer on the C2 and then reaming up to the canal. And this is a X-ray on lateral. You can see the drill and the forceps going through the C2 transcorporeal tunnel. And the first endoscopic view that I can see is this one. It's inside the disc, and I can fully, with some right angle dissector, I am able to remove the disc hernia there and clearly decompress the disc hernia. This is the point where I had to remove part of the annulus fibrosus after removing the disc herniation in front. And this is very important step. However, I did not remove the final annulus fibrosus fiber for fear of dural tear, because dural tear I will not be able to manage with the transoral endoscopy. So this is the end point. This is your C3 end plate, the remnant annulus, the lateral wall of the bone tunnel, a thin layer of the posterior longitudinal ligament, and the C2 end plate. And still pictures of how it was removed. And the last photo, you can see here the edges of the scope or the tunnel, or rather the cannula, which is 1 centimeter, and the opening of the bone is just 5 millimeter. And you can see here the opening in the mucosa, and upon closure, post-operative 3D reconstruction, you can see anterior and posterior, and the bone tunnel is there, very small, and the X-ray post-operatively. Neurostatus post-operative, after 2 weeks, the patient's biceps improved, the hand grip improved, the left improved, and the hand grip on the left also improved. The patient is now back, sensory is 80% from the neck down. The patient is ambulatory with improved bowel and voiding function. So the take-home message is that an endoscopic transoral transcorporeal approach for spinal cord compression is a viable option. Learning is constant. That's same as Dr. Alfonso Garcia mentioned. And you have no choice but to learn, and we have to do individualize our care and respond to patient-specific needs. The advancement stage is the formation of new knowledge, expansion of indications, and new techniques, and is an outcome of a continuum of learning as you go into autonomous stage and a necessary ingredient in solving a problem using a new philosophy. Thank you very much for your kind attention.
Thank you, Dr. Elmer. Thank you so much. I will now request you to stop your screen share. And can I please request Dr. Baban from Mongolia to start his talk? Thank you so much. Dr. Baban, are you with us? Please start your screen share. Yeah, thank you. Welcome.
Can you see my slide?
Yes, yes.
Yes, okay, thank you. Okay, my name is Norbert Baban, and neurosurgeon of, neurosurgeon, head of spine department of Grand Med Hospital, Mongolia. So my topic is about outcome of lateral recess stenosis with PSLD. So I think it's all familiar in this topic. So in 500 years ago, people thought that sun turns to earth, but Copernicus proved earth turns to sun. So this is a good example of paradigm shift. So endoscopic decompression also has paradigm shift example, good example. So between three years, I performed almost 700 cases. So on 250 cases of them was stenosis, and I performed endoscopic decompression. So I would like to introduce my results of my case. So we studied 100 cases, and mean age of them was 64.4. Mean operation time was 33 minutes. Mean hospital stay was 2.2 days. And canal volume changed 47%. And BUS score, ODI, changed like that. And patient satisfaction rate was 96%. So I would like to share with you what we have learned after 700 cases. Actually, in practice, it is easy to diagnose lateral recess stenosis from MRI. On sagittal view and axial view, we can diagnose easily. But unfortunately, we confuse sometimes in like this case. So in sagittal view and axial view, it's difficult to say lateral recess stenosis. In practice, such case, it's hard to make operation decisions. So, so we know that nerve root located not straight, so root located diagonally. So by the formal MRI, I mean axial view cut only at the disc level, we able to see a small part of the nerve root. So it's difficult to make final decision. If you want to see lateral recess pool, we have to MRI axial view widely. And so like this confused case, in my practice, clinical practice, I will follow the nerve root not up to from down. I am follow to nerve root down to up. So I am find pedicle and then follow the nerve root like this, up, down to up. So it's helped me to diagnose lateral ACEs clearly. So finally, it's my key point. In the axial view, we can see pedicle. And next to pedicle, located nerve root. So if you magnify nerve root compressed by the, in this case, by the ligamentum flavum. In this next axial view, nerve root located here, and if magnified, compressed by SAP, I mean by the bone. So this is operation case, for example, pre-op and post-op. You can see nerve root, ligamentum flavum totally removed in this case. From this slide, which nerve compressed by SAP, postoperatively poor decompressed SAP, and this line is entry point of scope. So we can small remove lamina, and we can achieve full decompression. So I think uniportal scope can make such achievement from small entry point and full achievement. So this is my operation video. So we start like this, and as you know that, so we are starting bone drilling, and we are trying to step by step and removing bone and ligamentum flavum and like that. This patient was very old patient, so really hypertrophied ligamentum flavum. So step by step, we are removing ligamentum flavum and go ahead and going. So in this video, I would like to show how to remove SAP, and this is, I am trying to remove ligamentum flavum under SAP, and so such case, usually in uniportal case, removing that part, bleeding too much. So it's difficult to sometimes controlling bleeding control. So I usually try to nerve roots gently retract by the dissector, retract smoothly, because I trying to release of scar tissues. And I recorded this video for this slide, so I cleared like that. Otherwise, I am not clearing such bone and head and scar tissues. And I want to show in this biting is important, because this is biting of SIP, and so it makes me clear, and this is also important. So sometimes I am using like that, and I want to show like this. For example, in this case, I am clearing for demonstration. Otherwise, I am not clearing tissues. So thank you so much for your attentions. And this is by Mongolian language, Bayatullah.
Thank you so much, dear Dr. Babin. Can you please stop your screen share now? We've had a wonderful session from morning, starting with Dr. Xavier, then Dr. Alfonso, both wonderful speakers. Dr. Elmer showed something very new to the world today. We really appreciate his talk, wonderful. Dr. Babin, you are a trailblazer in Mongolia. God bless you for all your work. And it was a beautiful and a very crisp presentation by you. I really appreciate all the speakers since morning, and thank you so much for giving your time to all of us. And now I take the opportunity and pleasure to invite Dr. Zhang from China to start his presentation. Dr. Zhang, are you with us? Please start your screen share.
Okay, can you hear me?
Yeah, I can hear you. Please start your screen share, sir.
Okay, I will share my screen.
And welcome.
Can you see it?
Yes, please. Yes. Can you enlarge it, please?
Okay. Thank you for your invitation. I'm Dr. Zhang Wei from China. Today's
Cara
topic.
itu sharing itunya gimana? Sharing screen. Dari sini atau dari sini?
Today's topic
Maunya.
is third portal of the UBE. The content includes the lumbar URBD, Jones portal, and lumbar quarterback key portal, and the double cage insertion by Jones portal and quarterback cage insertion portal, and the cervical URBD by the third portal and the cervical quarterback key portal. Jones portal is a contralateral portal. Is indication include first is easy to do the decompression of the contralateral side. The next is suit for the complex spondylolysis and to get more autographs for the fusion case. And it is easy to insert the second case by the contralateral third portal. And for the full decompression of contralateral side when we perform cervical UB and URBD. You can see the left side is ipsilateral view portal and work portal, and the Jones portal is contralateral side work portal. How to locate the Jones portal? I think is the mirror position of the ipsilateral work portal. First, I use the tip of the knife to locate the position of the Jones portal. Then I insert the first guided root under the monitor of the endoscopy. This is endoscopy and IF and the first root through the contralateral portal. You can use the endoscopy to monitor the whole procedure of the building the contralateral side portal. This is the contralateral IEP, and this is the inferior spinal process. We insert the guided root through this narrow area. This video shows how to build the contralateral portal. First, we build the portal. Then we insert the IF to clear the soft tissue, and I use the calcium punch to do the decompression of the contralateral side. The angle is very good, so it's easier to use the calcium punch through the contralateral portal. You can see the contralateral side, the upper margin of the laminar and the corner. We also can use the IF to control the bleeding. This is the corner area of the contralateral side. The facet joint. if we choose the obsilateral portal, it's difficult for us to do the decompression of especially the upper margin of the laminar. You can see the medial wall of the pedicle, and we insert the tube through the contralateral portal. And the decompression area include the contralateral, the upper margin of the laminar, and the corner, and the medial margin of the SAP. We also can insert the cage through the contralateral portal. This is a trial cage trial. So we insert the reamer through the Johnson portal, and we can see the trial. This video shows how to insert two double cage through the obsilateral side and the contralateral side. This is left is the cranial, right is the caudal side, above is the middle, below is the surgeon side. We use the RF produced by Bones company to clear the soft tissue in the interlaminar area. We can see the IEP, the lower margin of the laminar. This case is in the L4 and 5 level. We can see the laminar of the L5. Yeah, this is the laminar of L5 on the surface of the L5 laminar. We do the bone work from the basement of the spinal process. Until we found the insertion of the flavor ligament. This is the color. We can see the contralateral side, the flavor ligament, and the obsilateral side flavor ligament. We remove the bone of the basement of the spinal process to get the enough space for the work on the other side. We use osteotomy to remove the IEP from the inferior part. This is the apsilateral corner area. It formed the upper margin of the laminar and the medial margin of the SAP. This is important anatomy. Under the corner, we can find the nerve root. The blood vessel band from pedicle to the foraminal area. This is the medial wall of the pedicle. And the L5, the nerve root. We open the annular fibrous, and we make a window. We can use the radio frequency to open this area and insert the reamer to deal with the disc space. You can see the end plate. Insert the detectable cage 12. Then I test the remaining portion of the SAP. Then we build the third John's portal. You can see the contralateral side IAP and interlaminar area. The left side is IAP. The right side is the spinal process. We remove the contralateral IAP. We can see the contralateral side, the surface of the SAP. Then we do the decompression of the medial margin and the corner and the upper margin of the laminar of the contralateral side. we open the annular fibrosis of the contralateral side through the Jones portal. Then we insert the we deal with the disc space, and and insert the reamer. The whole procedure is protected by the UBE retractor inserted through the apsilateral work portal. We insert the cage trial. Then we insert the cage through Jones portal. We can see the cage through the apsilateral side. Then we insert the second cage through the apsilateral side. The contralateral side cage and the apsilateral side cage. This is a double cage. A quarterback key portal can mark the midline during the UBE procedure and to protect the nerve root by the key valve. And the free assistant make them happy and make sure the cage in the midline. The location of the quarterback key portal in lumbar is we can draw a line in the disc space level and the medial margin of the spinal process. The cross point is the key portal. This is a ULIF case. I insert the key valve through the quarterback key portal, and the assistant use the UBE retractor to protect the nerve root. Then I insert the key valve to block the nerve root. Then I do not need the assistant. So the whole procedure is very easy. We insert the cage trowel under the protection of the key valve. Another portal is for the extilief procedure, the quarterback portal. And for me, if I want to do the URBD in the extilief case, I often choose the third portal to insert the big cage. It is the lateral margin is the first blue line, then about 2 centimeter, and the green line is in the disc space level. The cross point is for the big cage. Cervical UBE URBD by Jones portal. The The location is similar to the lumbar transporter, but more above area, and I think it's very easy to do the decompression of the contralateral side laminar. This is a apsilateral decompression area of the UBE URBD. The apsilateral endoscopy portal and the work portal and the contralateral side the work portal. First, we expose the contralateral side laminar through the spinal process space, and then we build the transporter to remove the base part of the C5. Only removing the basement of the C5, we can see the contralateral side laminar of C5. You can see the surface of the contralateral laminar of C5. We did the contralateral side, the bone work through the third portal. It has a good angle to insert the instruments. We also can clear the soft tissue on the surface of the facet joint, the lateral mass of the contralateral side. We make thin the contralateral side of the C6 laminar. To separate the low margin of the contralateral flexible ligament. Then we do the bone work of the C5. Then to remove the flexible ligament through the third portal. is very easy and comfortable to insert the kerosene punch. If you choose the lateral side work portal, you must choose maybe the curved kerosene punch. This is a contralateral side flail ligament. We remove the flail ligament until we see the V point. Yes, we can see the contralateral side facet joint. This is a facet joint. Then we finish the whole URBD decompression. The cervical quarterback key portal is also very useful when you do the keyhole procedure or remove the disc herniation. This is a C4 and C7 case. We insert the key wire as a protective retractor through the quarterback key portal. Then we use the knife to open the annular fibrosis. It's very safe. The third incision allows the tools to be placed at a more comfortable angle and make the decompression procedure to be more direct. Right. We can only use two portals at the same time, which is technically a two portal technique. Just like the shoulder arthroscopy, focus on the solving the patient's problem rather than focus on the number of the portal. Thank you for your attention.
We have
5 minutes left.
Dr. Zhang, thank you for a very, very wonderful and a beautiful presentation. I really don't have words to express. This is the first time that I have seen somebody do biportal cage insertion through a biportal technique. It's amazing. And it's amazing your concept and grasp of the anatomy of doing the SAP osteotomy on the contralateral side, getting extra exposure for the discal surface so that there is not much of cord retraction, and then inserting the cage on the opposite side. It's a wonderful concept, believe me. I am grateful and I've really appreciated your lecture today. I have 2 minutes, so I would like to surmise some things that I've been observing since morning. First of all, I thank all of you for giving a very crisp and on-time presentation. Dr. Xavier, your talk was wonderful on how to give a stepwise build up to a surgery, including preparation of the OR. Dr. Alfonso, you gave us a very beautiful talk on monoportal and jumping techniques in the cervical UB, as well as the very fact that you mentioned a very beautiful line which has remained with me all my life. And that is that we are all learning. Elma, Ejam, you have rocked the boat today, buddy. You have given a fantastic presentation on a very new technique and amazing, amazing. I really don't have words to express it. It has been a very rich morning. Dr. Baban from Mongolia, you have been a trailblazer. You are really a torchbearer of your master. And your work in monoportal, in cervical and lumbar is only to be appreciated. Lastly, I will again conclude with a big thank you to Dr. Zhang for his talk on the third portal and the advantages of a third portal in exposure of the contralateral foramen, decompression, and also in insertion of a contralateral cage through a small biportal technique. So today morning has been a wonderful, wonderful session. I'm really grateful to all of you. I will now invite our next speaker, Dr. Tian Dashang from China. I hope you are with us, Dr. Tian, and please start your screen share.
Hello, can you hear me?
Yes, I can hear you, sir. Welcome. Please enlarge your screen.
Thank you. Okay. Thank you for inviting. Everyone, my name is Tian Dasen. I'm glad to share the discuss the UBE technique with everyone here. My topic today is application of the UBE technique in thoracic ligamentum flavum ossification and ligamentum flavum of the thoracic vertebral complexes. The spinal cord, resulting in somatosensory and motor dysfunction, such as low limb pain, numbness, weakness, and even defecation disorder. At present, the common classification of the TOLF is status classification, divided into 5 types. The purpose of the classification is to guide the model of operation and prognosis. Before TOLF surgery, it is necessary to judge whether there is a dual ossification, and whether there is a dual ossification directly determines the choice of a surgical strategy. There are the 3 singles of dual ossification in CT scan, which are tremor checker sign, coma sign, and a bridge sign. Be sure to read the CT scan carefully before operation. At present, the surgical treatment options available for TOLF as follows. Uncover thoracic spinal canal posterior laminar resection, microendoscopic spinal canal decompression, lateral foraminal decompression of the spinal canal, posterior unilateral bipolar endoscopy spinal canal decompression. Next, I will use the few specific cases to introduce the skills and precautions for thoracic spinal canal decompression and UBE technique. Case 1 is the first case that I have done. The patient is a 57 years old man suffering from numbness and weakness of both low limbs for more than 1 month. He can't walk and enters the hospital in wheelchair. Let's check the pre-operative radiological data. MRI shows that there is a compress in the segment of T9 to 10. The CT scan shows that the compression of T9 was severe, and the ossification mainly come from the left side. The ossification in the T10 is small, mainly from the right side. The diagnosis is the thoracic ossification of ligamentum flavum. For this optional surgical methods, we choose UBE. UBE means unilateral bipolar endoscopy. Everyone is familiar with it, so I won't repeat it the detail. And one ossification is on the left side, and the other is on the right side. How to show the approach, left or right? Because it was the first case, I know you period, so I chose the severe compression side. That's the left side. There are 2 compressed segments, one with light compression and the other with heavy compression. We first show the segment with light compression to decompress. The video shows the beginning of the operation. The ball cut the bone along the root of spinous process to the opposite side, just like the ULBD surgery. And for the T10 segment, we use over the top decompression. The more the moving of the top structure is used to explore the full picture of the ossification going from the tail to head along the dual matter surface to remove the compression until there is no compression of the dual sac. For the T9 segment, we take a ipsilateral decompression. I can be seen in the video. There will be a blending area of visual field when finding the lamina, which is difficult to grasp these tubes. And there are similar problems in the use of lamina wrangler. During the observation, there was found that there was a tension between the ossification and the dual matter, which was separated carefully, and finally the ossification was completely removed. The ossification should be separated by head to tail traction, and not horizontally. This is the 3 skin incision. This is MRI 3 days after operation. We can see from the ossification has been removed. This is the CT scan. We can see the operation has been removed. This is the 3D CT scan 3 days after the operation. And we protect the joint as possible as we could. This is my image that a patient come for review 4 months after the operation. It shows the deep compression of the duodenum. This the compression of spinal nerves has been relieved. This is the incision 4 months after the operation. The video recorded the review in 4 months after the operation. The patient could not walk before the operation, but now he can walk freely. And next, let's look at the second case. The patient is 52 years old female, suffering from weakness of both low limbs for more than 1 year, and both low limbs muscles atrophy. Pre-operator MR showed that there was a compression in segment of T11 to 12. The CT scan indicated cases that the ligamentum flavum at T11 to 12 has been ossified. The cross-section CT show the compression mainly come from the right side. We diagnosis as the ossification of so that's called ligamentum flavum, the lumbar spinal stenosis, and right peroneal nerve injury. Because the compression mainly come from the right side, so we choose the left side as the approach side. This video shows the operation process. The first video 1, decompression across the top from the left side can reveal the full picture of the ossification and detach attention to the dual matter. The video 2 at the distal end of the compression, a small calcium puncture can be used to bite the distal bone. The video 3 at the distal end of the compression can be pushed with a power jaw. The video 4 pay attention to the position of the grinding to avoid the bounce of power jaw and the spinal cord injury. 这个更长，说了。Post-operation MRI showed that the spinal cord compression had been reduced, and the ossification cannot be seen in the post-operation CT scan, so the decompression is complete. The 3-dimension CT shows that the damage to the facet joints is very small, which is a benefit to the long-term stability of the spine. Let's look at the third case. A patient is 74 years old female, suffer from numbness and weakness of both lower limbs for more than 2 months. Pre-operative MRI showed that there was a compression of the segment of T11 to 12. That's the 3D scan suggests that the compression is ossified ligamentum flavum. The CT scan shows there is a compression on both sides, and we can see from the cross section the compression on the right is more serious. The diagnosis like case 2, thoracic ossification of ligamentum flavum. And during the operation, the relationship between the position of ossified ligamentum flavum and the spinal canal structure can be seen, and the endoscopy, which can greatly reduce the risk of intraoperative spinal cord injury. The video shows how to carefully separate and remove the ossification in backbone. During the operation, decompression should be performed at the same time of exploration. Once enough, decompression is stopped. Excessive decompression should be prevented. If the girdle is at a hair joint to the lamina or ligamentum flavum, it must be carefully and avoid tearing the girdle or injuring the spinal cord. And we can see from the CT that the decompression of the bony spinal canal is satisfaction. The 3-dimension CT showed the extent of lamina bone window resection, and the facet joints were protected well. And the vertical view of the 3-dimension CT shows the complete ossified resection in the spinal canal. Tips. Finally, our experience in the treatment of TLF with the UV technique as follows. Suitable for single or multi-segment ossification of ligamentum flavum. For double segments, the segment with light compression should be selected first. The contralateral approach was selected for unilateral compression, and the side with light compression was selected for bilateral compression. Start with the base of spinous process and the head or tail of ossifying ligament. Precise decompression can be achieved according to the ossification range during the operation. In general, UV technique has the advantage of safe operation and complete decompression in treatment for TOLF. So I think you comfortable with a single channel. Dual channels will make you even stronger. That's all. Thank you for your attention.
Thank you, Dr. Tian. A wonderful presentation. It was a very difficult surgery. Thoracic ossification of the phlegm is a very difficult surgery to do. There's a lot of risk involved of aggravating neurological damage, but you have shown it in a very wonderful manner. You have taught like a true teacher, because it's only a true teacher who expresses the methodology of doing a particular problem. And you have laid down those criteria and you shared that with us. So that is, I think, a very appreciable message to be sent to the entire world. I thank you on behalf of the Egyptian World Congress and on behalf of the Endoscopic Spine Foundation. Thank you very much for your talk. I will now invite our next speaker. Can I please request you to now stop your screen share, sir? Please exit your screen share, Dr. Tian.
Yeah,
thank you. And now I will request our next speaker, Dr. Ji Weibing from China, to give his talk. Thank you so much, sir. Welcome.
OK， 全屏。哪里是可以全屏？哦。
徐主任在那个放映那里，幻灯片放映有一个全屏。
上面是下边，上面是下。
上面有幻灯片放映，在后面，右边幻灯，就是切你刚才那个地方。看开始那个地方，第二个插入第三个设计，第四再往右边，再一点点。
幻灯片速度开始，对，抱歉。
对。
OK， my topic is because I just finished my operation. I'm now in my OP room. My topic is some changed. My topic is the history and the technical details of UB-based ULBD. I'm Dao Xu from China. My topic includes 3 parts. First, the history of the ULBD. Second, the lumbar ULBD case by UBE. Third, the thoracic ULBD case by UBE. ULBD means unilateral laminectomy for bilateral decompression. The indication for ULBD include the central spinal stenosis and the both side lateral recess stenosis. Sometimes include foramental stenosis. This video is the ULBD. First, let's talk about the birth of the ULBD. In 1995, American doctor Polity came out with the idea of unilateral laminectomy for bilateral ligamentectomy to treat 2 cases of lumbar stenosis caused by ligamental fluid hypertrophy. The author believes this can preserve parts of vertebral arch and the spinal process. Also can preserve supraspinous and interspinous ligament. So it can reduce spine instability caused by wide laminectomy. The German doctor Sept formally described the technical details of ULBD under microscope in 1997. First, he do the cadaver study. Then he also do the clinical study. He first formally present the technical details of ULBD. From the figure, we can see the ipsilateral nerve root and the contralateral nerve root. We can see it clearly. ULBD based the concept of reducing post-operative instability caused by wide decompression surgery as much as possible. Let's see the first case. My first case is a 70 years old female. Both leg weakness and numbness, neurogenic claudication. We can see the patient have a severe lumbar stenosis and spondylolisthesis. It is fixed, no instability, grade 1, and cauda equina syndrome. There are many treatment options, include belief, TLIF. We choose the UBE, ULBD. My option is ULBD. First is the beginning comfort. It is the spinal process. The bottom is artificial. This is the beginning camp. Then we do laminectomy with burn autotome and also calcium punch. This is a ligament flavor, dark. Maybe it is a necrosis or ligament flavor. Then we separate the adhesion between the ligament flavor and the dural sac. Separate the adhesion between the ligament flavor and the dural sac. No dural here in this case. Then it is the contralateral exiting nerve root. Contralateral exiting nerve root, and the contralateral transversing nerve root. It is the middle part of pedicle. This is the ipsilateral transversing nerve root. So from we decompress the 3 nerve root from ULBD. This is the preoperative CT scan and the postoperative CT and MR. Pre-operation post-operation. Second case is the right leg pain. Right lateral recess stenosis combined with foraminal stenosis, compressed L3 and L4 two nerve root. We choose contralateral over the top decompression. Contralateral decompression over the top. We decompressed both exiting nerve root and the traversing nerve root. This is it is exiting nerve root. By the UBE base contralateral decompression, we decompressed both exiting nerve root and traversing nerve root, and preserved articular. It is the traversing nerve root. And the middle part of pedicle, traversing nerve root. Also, the ipsilateral nerve root be decompressed. Post-operation, we do the over the top decompression, decompressed both exiting and traversing nerve root, and preserved articular. Next, let's see the thoracic ULBD case. Thoracic, it is 65 years male, a complaint numbness and weakness of left leg. The diagnosis is thoracic stenosis and congenital stenosis. The stenosis because of the ossification of ligament flavor. We do the thoracic ULBD where the UBE base. It is calcified ligament flavor. Calcified ligament flavor. First, we find central folding from the disc SP base. Central folding. And so then with a diamond burr, we do the contralateral decompression along the deep layer of ligament flavor. Contralateral decompression. Pre-operation and post-operation. The patient can walk by himself. Before operation, the patient couldn't walk. by himself. So UB-based is a endoscopy assistant open surgery. Thank you.
Dr. Wiebing, a fantastic presentation. Thank you very much. From all my colleagues and friends in China, I'm really grateful for your beautiful talks today. Dr. Wiebing, you have shown us UBE as a new frontier in decompression of scoliotic spines. You have done ULBD in a scoliotic spine, which is greatly appreciable because of the great distortion of the anatomy. It requires great skill. So I appreciate your skill as a fantastic UBE surgeon. God bless you and thank you for your talk. I now invite Dr. Srinivas Rohidas from India. He is one of the greatest leading exponents of the Destandu technique and perhaps one of the only surgeons in the world to use 3D technology in this form of endoscopic spine surgeon. Welcome, sir, and please start your screen share. We wait your talk.
Good afternoon. It's okay?
So please start your screen share, sir.
1 minute. 1 minute.
Great, sir.
Okay?
Yes, sir. Please
Yeah.
enlarge. Yeah. Thank you, sir.
So, thanks for the opportunity to talk about the technique which I used and about the 3D endoscope. Am I audible? It's okay? Hello?
Absolutely audible, sir. Fantastic. Go
No
ahead.
problem. It's just if there is any problem in between, just give me SMS on WhatsApp. Okay?
Yes, sir. Definitely, sir.
So this is about 3D endoscope, endoscopic spine surgery with distant use technique. In 1990, Baker et al. First described 3D technology for endoscope. That was the initial stages of endoscopy, allowed better recognition of the relationships of the anatomical structures and makes precise differentiation of the tissue layers. I'm using this 3D endoscope with Destandu technique since 2015. In 2015, 14th for 2015, I used first 3D endoscope Vision Sense. And specifically, I used this endoscopic technique for removal of a D12L1 intradural tumor so that the depth appreciation is quite appreciable and I will be able to know how it works. From 2016 to 17, I use Mashida, which converts 2D into 3D by converting the videos, distorting the videos. And from 2017 onwards, I'm using TipCam 3D. This is the thing which started spine endoscopy and neuroendoscopy in 2002. Initially, I was interested in neuroendoscopy, but later on started specifically doing spine. This is the basics which I follow. How to choose your love. You have to work on subject which others have not worked on it, not explored yet. Focus on it, do it persistently. Let others know about it. You have to present your work honestly. The important thing is you have to choose. You cannot become master of all techniques. It is not a philosophy like Amazon, where you can provide each and everything of a best quality to each and every patient. So you have to choose your love, and that is very important, which I did in 2002. Now the applications of the MISS does not require latest technology initially. In the further talk, I'll explain you how I started and what led to a 3D endoscope. But it does require and willingness to minimize the collateral damage. You should reevaluate the current thinking, generous use of endoscope. The patient understands the word endoscope rather than the word MISS. So always remember, keyhole or miss or endoscopic spine surgery refers to concept, not to the size of the incision, and patient inherently understands the word endoscope. The latest technology will help you in creating your brand value. This is in 2004. This is Dr. Distandu. He is the pioneer of this technique. And this is what we started. This is single chip camera, halogen light. And we used to use a 14 inches Sony TV. And when we went to the patient in the conferences, there was always a skepticism that there is no depth appreciation. We have to understand the anatomy. This is in 2006, and this is the 14 inches Sony TV with a single chip camera. But we continue to have education of the surgeons learning programs. This was the first workshop. This was the second, where we use a 3-chip camera. Then in 2006, we started with anterior cervical, where we had to use drill because we have to remove end on bone at the joint, uncovertable joint. This is the vertebral artery. You are near to the vertebral artery, medial to the vertebral artery. And there was always stress. This can happen accidentally. This is a drill, and you can catch the muscle, or it can happen to the neural tissue also. Then we thought of a ultrasonic bone dissector for safe removal of the bone, because the vision was not that clear. It was a 3-chip camera, single chip camera, no depth appreciation, and we thought of a ultrasonic bone dissector along with the company called Zuring. And these were the tips which we had prototypes. We finalized the tip, and it was little bit of a stress relieving thing. Now this is single chip camera near the vertebral artery. This is the vertebral artery under my suction, exposed medial part of the vertebral artery. This is inside the canal in the anterior cervical going on the opposite side. But still the depth appreciation and the precise anatomy was not that clear. Then in 2008, it was the high definition camera, and everything changed. This is the midline in between the two flavum. This is the lamina on the right side, and you can judge the depth by differentiation. This is the lamina, this is flavum, tip of the instrument, and you have to learn how to judge the depth. We were a little more aggressive because of the crystal clear picture. This is the curate to detach the flavum, and underneath is the dural tube here. This was in 2009 HD camera, and we used the ultrasonic bone dissector for safety. We could go inside the disc space also through the working channel and have a look at it at depth. And this is how we can judge the depth. This is the traversing route. We are inside the disc space, both the end plates. But still, there was always skepticism that there is no depth appreciation. So this problem was overcome by reconstruction of the anatomy in surgeon's mind through the use of multiple landmarks, but this requires additional effort a steep learning curve. That was the important thing because of this 2D, and a sort of a telekinetic slowing of these surgical actions. So this is about the 3D by Baker. Then we had the options, a conventional telescope type stereoscopy, where the two separate endoscope channels are used. But when there are two separate endoscope channels, the diameter cannot go below 8 to 10 millimeter. But for spine, we needed a 4 millimeter diameter endoscope. So the options available were Vision Sense, Mashida, Avion, and Stors. And there was other option, 3D video converter, which converts 2D image into 3D by distorting the images by Mashida. Now this is the Vision Sense. A left eye video, which is 2D, with understanding of the anatomy. This is the traversing route. We are going inside the disc space. This is the traversing route, ligamentum flammum, bilateral canal decompression. Traversing route on the right side. This is on the left side. This is the endoscope. Two eyepieces, 24 inches monitor. Now in this technology, it is an insect eye technology which incorporates a micro array of lenses similar to the compound eye of an insect in a single video chip. There was a single video chip at the end of the endoscope. And this in turn generates multiple small images. Those are processed and divided into simultaneous left and right image. The left image is crystal clear and right image is distorted. That's how we get the depth appreciation. This is how it works. Now, this was the first case which I did on 14/4/2015. You can appreciate the arachnoid also. This is the dura. When I put the patty, the arachnoid was pushed down. This is the nerve root. This is at D12L1. This is the rudimentary nerve root from which the neurofibroma has come out. All these patients are mobilized after 2 to 4 hours. Most of the patients, 90 to 95% of the patients are not catheterized, no drain. You can use micro scissors. You can use endoscopic bipolar like a regular bipolar. This is the bipolar. And they cut the nerve root and remove the neurofibroma as a single piece through the outer tube. This is canal decompression, ipsilateral nerve root, shoulder, axilla going down, contralateral nerve root. You can zoom in also. Now, in this case, the camera is fixed to the endoscope, as endoscope has two lenses for two images, left and right. Now, there has to be a modification in the locking system of the endoscope. The usual locking system of a routine endoscope is not useful, so you have to change, because this configuration you cannot change. This is not a circular endoscope. So you have to change that. Then I switched to the Mashida, which converts 2D into 3D. In 2016-17, I used this technique, which distorts the images, and you have a 3D feel. The images are shifted to the 3D converter, it distorts the images, and you have to use 3D glass for the depth appreciation. Now, the best part of this is you can use a routine endoscope. At the same time, you can have a 3D appreciation with a panoramic vision, with a zoom effect also. So this is 2D recording of the case where I have used a 3D converter. You can appreciate the epidural veins also. Then since 2017 October, I used this STOR's TipCam 3D. It has two chips at the tip of the endoscope. This is the TipCam 3D, very light, 18 centimeter length, 4 millimeter diameter, 0 degree. This is how we can use it. It's a very light. We get two images, left and right, and when they fuse, we get the 3D appreciation. Now these are the two videos, left and right. This is the disc. This is the traversing route. You can see, you can zoom and get a magnified view. These are the capillaries over the nerve root. This is the area annular tear from where we have removed the disc. It's just like UBA, only the air medium is there. So till now, I have operated with the 3D something around 538 cases after October 2017 with TipCam 3D. Lumbar cases 504, cervical 16, anterior, cervical posterior 14 cases, intradural tumors 14, and thoracic 4. In spite of a very good depth appreciation, crystal clear images, you can have complications like 5 dural punctures in 504 cases, 3 cases of canal stenosis, and 2 cases of listhesis. There was no need of suturing the dural puncture. Fibrin glue and tissue dura patch helped us to stop the leak. So we successfully carried out with the distant use technique the 3D endoscope without any extra time or fatigue. In fact, definitely less operative time, as there were no vague or blind movements. It was easy for beginner, starting for the case 1 in 2015 also, as there was no need to learn technique of appreciation of 3D out of 2D. Suitable for complicated cases like reoperations, severe fibrosis, intradural tumors or cervical anterior, where the operative area is something around 10 millimeters by 8 millimeters. It's definitely best for canal stenosis. Go on the opposite side by angulating it. Now there are pitfalls and tricks to overcome. 3D endoscope, it is a tubular vision. There is no panoramic vision. Now the basic advantage of the endoscope when the endoscope came into market was the panoramic vision in the periphery. So you cannot have a zoom effect which is there in the 2D camera and the endoscope, where the camera lens can have a zoom effect. Now in 3D converter of the Machida, we use a 2D endoscope. That's why we can have a zoom effect because of the camera. But still, as there is no panoramic view, all the endoscope field has the same illumination with the razor type sharp images in the 3D. Now, this is one more important thing. We cannot use 3D with UBE because it's too costly, as frequent chances of damage to the lens of the endoscope by the drill, because it is a single hand technique. And this instrument is too costly to be spared with the injury. Now, what are the advantages of the 3D endoscope? 3D appreciation will definitely decrease the steep learning curve of the endoscopic spine surgery. 3D anatomy helps in explanation of the disease anatomy, like compression of the nerve root on the opposite side, to the patient's relatives also, and to the patient himself during the preoperative counseling. 3D appreciation definitely helps in reducing the complications related to the depth appreciation. Now, the disadvantages are there is no panoramic vision. Why? As there are two chips which are creating videos, and it's a tubular vision. Now, this is a distant use technique. This is the outer tube and the inner tube, and we have a sliding effect in between the two tubes. So the telescoping effect in between the outer tube and the working insert helps us in having the magnification. This zoom effect, by zooming, we can get into the magnified image and have inspection of the operative area. By pulling out the working insert, we can create our instruments and use that space